My name is Eddie Stens. I'm the Regional Purchasing and Distribution Manager, and I'm a co-lead for RPIW 44. What we have there is our standard work combination sheet. There's 10 of us, and we'll be working to a takt time of 20 minutes. This is our team. We're called the Screen Saviors because we worked on a suicide risk screen for the emergency room. We were tasked with this project. This is the first design RPIW in the region, and the target statement is design and implement a process with use of suicide prevention protocol for intervention and treatment of patients presenting to the emergency department. The current situation is that not every patient is screened. Actually, very few patients are screened. There's a lack of comfort and competency in screening, a lack of awareness that this is a requirement for every patient who reports to the ER. Tools designed for mental health and addictions did not work for the ER, and there's a host of other problems we were coming across. Now, this was a provincial mandate about 2 years ago was made to have every patient screened for suicide risk. Also, there was one critical incident that has an outstanding recommendation for implementing the suicide prevention tool. And off we go to our target progress report and results sheet. The walking distance is based on multiple trips to the ER for patients not identified, so that would assume that they would have to come back either once or more times because they were not identified at the time they were here. The reduction in the number of items in both the med fridge and the eye tray that we did as part of a small 5S were the inventory reduction. Lead time is from start of registration to patient disposition, and it's not our intent to change that. Quality, some of that quality readings are referring to the small 5S we did in the previous weeks leading up to event week. But the most important quality points are the patients not seen or not screened and leaving the ER without a safety plan. The productivity gain, what we're working towards screening every patient coming to the ER. Cycle time, we did measure the triage processing time, but we had no intent to reduce that time. We just needed to make sure we were aware of any impacts a new process would have on them. This is our current state value stream map, and we identified some starbursts here, and those are problems. One was the lack of privacy in the admitting and triage exam rooms affecting the ability to screen patients. One was no consistency in the use of existing tools, and we wanted to make sure not to forget the adolescents and children. So anyone under 17, we need to remember that even though if this is not covered in this RPIW. This is the time observation form we used to get our measurements for the value stream map. This is how we calculated takt time. That's based on approximately 80 patients a day going through the ER. And that would mean that every 18 minutes, a patient has to have its disposition decided. Our PQA data was quite interesting. Out of 534 patients that came in to the ER in 1 week, 375 of them were discharged, which means 375 people went home without a safety plan, without a screening for suicide risk. So this shows it in a different way. 5% of the total visits to the ER, the chief complaint was in the mental health category. So that means 5% of people did get screened and did have someone give them a suicide risk assessment. Also, they were taken care of that way. Whereas the other 95% were medical complaints. We want to cover all of them. This is just a bit of evaluation information on the small 5S that we did. We did the medication fridge, cleaned that up, and we also created a new eye tray. And it's still in effect, so it's working well from what I hear. The score at the time was 1.1, so not so great. That's the fridge, and that's the messy eye tray. And by the time we were done, it was a 2.6 score, which was very good. And that's the cleaned up fridge. and the brand new iTray, which is still in use and working quite well from what we've heard. As part of that little 5S, we did some standard work, and there were 3 pieces of standard work created that came out of that, and they were around the med-fridge temperature logging, which wasn't happening, and really does need to be, and cleaning and stocking the new iTray, and open medication labeling. That's it. April?
Hello, my name is April Brown, and I'm one of the licensed practical nurses that work in the emergency department. And on one of the idea summary sheets, one of the problems that we realized was there's a lack of training and experience to identify these patients that are registering. So the measures we took to deal with that is we created a tool, and we're calling it the Suicide Screen and Risk Level Assessment Tool. And it's a 2-part screening, and the first part, the nurses are going to be doing the screening. Second part is done if they trigger or not, and that's where the pathways come in if that patient triggers. And these are only on patients right now that are 17 and older.
Hi, I'm Cheryl Fair, and I'm with Mental Health Outpatients in the intake team. And so we started to look at the problem of who takes responsibility for the safety planning and arranging and follow-up. So a measure that was taken is a process was created for having services lined up and those services contacted. And the result was that ACAP, Mobile Crisis, and the nurses are going to be doing that arranging and the safety planning. So the pathway is the patient presents at registration and the screening form is given out to them. And then the initial screen, 3 questions, is done by triage or another ER nurse if triage does not have the time. So if there's nothing is triggered regarding suicide, the process is completed at that point. If something is triggered and it's between the hours of 8 p.m. and 8 a.m., then the nurse will perform the risk assessment, and then they will be seen by the ER physician, and the nurse will notify the ER physician of the risk level. If the ER physician decides to discharge the patient and they are low risk, then the nurse is going to do a safety plan with them, and then they'll fax that on to the appropriate agency, and the appropriate agency being mental health, addictions, or an agency within their local community, because we serve a lot of clients in other health regions as well. If it's medium or high risk, then the nurse is going to contact Mobile Crisis, and Mobile Crisis has been great in being a great support for the emergency room. During the hours of 8 a.m. to 8 p.m., the nurses are going to contact ACAP if a patient is identified at risk. Then ACAP is going to do the full assessment and determine the risk level if nothing is needed, the process is completed. But if the physician wants to discharge the patient, then ACAP will complete the discharge safety plan and fax it to the appropriate agency. So if they are within Prince Albert and they're low or medium risk, ACAP is going to phone mental health, and mental health will provide with the appointment date within 7 days if it's low or medium. And if it's a high risk with NPA, then ACAP contacts mental health and they get a 24-hour follow-up appointment with addictions or with mental health services.
I'm Vicki Bird with Mobile Crisis. Mobile will be called after hours to provide a safety plan for any patient that's medium to high risk. The safety plan will be completed to keep them safe in the community until ongoing services can be in place.
So my name is Jolene McLeod, and I work on the provincial implementation team. So when we were thinking of safety plan, we looked at an idea summary sheet with the problem being that patients identified at risk of suicide that were discharged, that weren't admitted, weren't necessarily going home with a safety plan. So the solution to that problem was to develop a safety plan that we adapted from the one currently being used by mental health and addictions, so to keep it standardized. So that will be utilized by ACAP, as Cheryl had mentioned, during the hours of 8 a.m. till 8 p.m., as well as by Mobile Crisis in the evening. But that didn't solve all the problems, so our next idea summary sheet had to look at the different hours from 8 p.m. to 8 a.m. So when ACAP wasn't available. And so because nursing time is in such a high demand, we realized that nurses didn't have necessarily as much time to complete the plan, so we needed to look at doing one that had kind of a condensed version, but still ensuring that the patient was going home with a safety plan. So that was our next problem identified, and the measures taken were adapting the form to create a shortened version of a safety plan that will be utilized by the nursing staff during the hours, again, of 8 p.m. until 8 a.m. And then in addition, I guess I should say, to that, mobile crisis will be coming in to help complete safety plans on patients in the emergency room in the hours of 8 p.m. till 8 a.m. with moderate to high-risk patients. So that was very grateful of Vicki to offer that up as support to the staff. And then in addition, the nursing staff will be doing assessment or safety plans on those clients that are low risk.
Hi, I'm Michelle Blair from Community Mental Health Nursing. One of the problems identified that kind of came around out of the safety planning was the lack of educational resources provided to the family and to the patients or support people when they're discharged. So we came about adapting two information sheets that they may take home. The one provided to the client gives information about what to do if they are having suicidal thoughts, how to cope with them, understanding their thoughts and their feelings, provides problem-solving skills, and what to do in a crisis. The handout that can be provided to the support person provides information on depression, the warning signs of possible suicide risk, how to keep the person safe, and what to do in times of crises.
I'm Val Middlebrook. I work with nursing administration, and I'm also working towards completion of my lead leader certification as a participant in this RPIW. So in this idea summary sheet, we identified a problem of the client not necessarily receiving follow-up services in their own community, because of course we do serve many other communities other than Prince Albert. So the measure we took was we provided ACAP and nursing with contact phone numbers for outside agencies. Added them to the forms developed whenever possible, just for ease of access for those to use them. This second idea summary sheet, we identified no standard pathway for patients identified at risk to be referred to mental health addiction services or their GP. So the measure we took there is we developed a work standard to refer as appropriate following the pathway. Additionally, we developed work standards for the entire process for all affected departments for clarity in the process to make things as seamless as possible.
One of the other lean tools we used is the Kaizen spaghetti diagram, which it traces the patient's steps through the ED. No suicide screening may result, of course, in multiple trips through the ED and multiple steps. Our pre-Kaizen standard work combination sheet shows cycle times and wait times through the process. The key times we were watching were the patient triage times and the time the nurse spent with the patient once they got to the bed. This is the times we're expecting the implementation of our screening tool. The pre-Kaizen present load chart shows how the workload is currently spread out in the ER. And again, the two times we were concerned with was the triage time and the ER nurse time. The post-time observation form, we followed patients through the ER with the suicide screening in place. We found no major changes from pre-Kaizen times. From our time observation sheet we created the future value stream map. Screening actually was done during triage or while the patient was being seen by the nurse. We noticed very little increase in time for the processes, meaning that the screening was not affecting their day-to-day work. The 3 unresolved starbursts that we've moved to a parking lot to be dealt with in future RPIWs are the lack of privacy in admitting triage and exam rooms affecting the ability to screen patients, how we're going to deal with adolescents and children under 17, and the patients who leave before they're triaged. The post-Kaizen spaghetti diagram. We expect the implementation of the suicide screening protocol will eliminate multiple trips for flagged patients. Our spaghetti diagram shows a reduction of patient steps by at least 50%, or depends how many trips we do save. The post-Kaizen standard work combination and percent load charts show that our added processes have very little impact on the ER times they take to do their work. Triage and ER nurse times have very little, as the initial screening, it takes about 30 seconds. There was major concern where we would fit this in, but in the few days we've been trying it, there's been no real complaints. We also created 2 multi-skill training checklists for ER and ACAP staff training. And we're well on our way in implementing the training. Our final target report sheet, or post-target progress report sheet. Our 5S made the improvements we show here. I guess the main things I'll talk about is we're of course going to reduce walking distance for flagged patients because we're going to avoid multiple trips to the emergency room. Under quality, our 5S, the number of items in the med fridge was reduced by 100%. The number of expired items in the med fridge was reduced 100%, and the number was reduced 100%. I'm sorry. 100% of patients not screened in the ER is what we had when we begun our process, and now we're seeing that only 39% are not being screened, meaning in the first week we're implementing this, 61% of the patients that present to the ER are being screened for suicide. Our RPIW newspaper, 14 of 21 items are 100% complete. The remaining 7 we will hand off to our process owners and hopefully will be dealt with as time goes on. They include, we need better ACAP stats for the ER. We want to continue rolling out the ER screening form. Can ACAP presence in the ER be increased? Psychiatry needs to be consulted and on board with what's going on with this process. We need to implement registration as originator of the screening form. We have to continue training staff for ER and ACAP staff, training for ER and ACAP staff, and we have to continue training our registration staff.
Good afternoon, I'm Lorraine Young, I'm the family rep. Lessons learned. Implementation takes time. When you think you're done on Tuesday, well, you've just begun. Communication and feedback from frontline staff is so essential. Working collaboratively with other departments is key. And it's important to know how your changes will impact processes following. And Gord will provide his recipe for shortbread.
Thank you. Good afternoon. My name is Gord Hine. I work as an assessor with the Acute Care Access Program, the ACAP. It's kind of hard to imagine and enforce 4 little points. That's what we did all week, but they're huge. So we developed a suicide screening tool that's never been used before, and it's implemented. We've developed a safety plan and a care plan for those who have been flagged, and we have work standards developed for all the departments involved. And we've implemented and tested the plan, and I've talked to mental health, and they're getting reports and communication with ACAP already. It's already happening, so it's a little scary because I don't know if we're all ready for it, but we have to do it. Just want to say thank you to many people this week. We did it in the form of a tree of growth because it's lots of change and we're keep on spreading out and serving where we can. Yeah, just to all the departments, to Carol, to Alana, to Tracy, to the physicians. Client access was amazing to help us. Mental health, inpatient, outpatient, it was good to work with them. Mobile crisis to come from the community into our system to help us. It's just been great to have everybody involved to do it. So to sum it up, we're going to end with a little bit of a change in the format, and I have to give credit to Brett because he encouraged me the other day about something that I've been planted a seed. So we're going to end with a song, and thank you to Spencer Davis. We have to give him credit. So it's to the tune of "Give Me, Give Me Good Loving," and if you want to join in, just join. So whoever's Blues Brothers fans would know this song, I hope. Well, the work is chaotic. There's stuff on the floor. Here comes RPIW number 44. We've come together at the Gimbo, yeah. Jadoka Can Band, get real and Muda, yeah. Here we go. Give me some tack time. Give me some tack time. Gonna be so lean now, everybody now. We're gonna be so lean.